Good evening everyone and welcome to the Primary Care Update number 4 on COVID-19. Can I say thank you for attending and acknowledge the traditional owners of the lands on which we're meeting and pay my respects to elders past and present and future. My name is John Bailey. I'm the Executive Manager of the Primary Care Improvement Team here at Hunter New England Central Coast Primary Health Network. Just wanted to provide you a bit of an update on a couple of issues before handing over to our team so that they can provide you with updates on other specific areas. Firstly, related to Commonwealth-funded community respiratory clinics. I'm pleased to be able to say that the Raymond Terrace Clinic is set to open on Thursday of this week, following a bit of a process, but they've undertaken their infection control training and will now move to the active phase. Our site at Toronto has been inspected by Aspen Health and is awaiting Department of Health approval and issuance of the contract. Similarly for Tamworth and Erina. We've finally been able to identify a preferred site in Taree and are awaiting approval from the department to undertake inspection for that. Once they're up and running, we'll communicate those to you through our Health Pathways site. Just wanted to also reinforce the ordering process for masks from Hunter New England Central Coast Primary Health Network is via the website. From today onwards, you will get an email confirmation that your request has been processed and is on its way with a contracted courier service. I'm also able to advise that we've increased the number of boxes we're able to supply each request to 2. At this point in time, we still have access to the national stockpile, and we currently have approximately a week and a half supply of masks. Also wanted to let you know that we're doing some work in the aged care space and then working with NHS UK to develop an app and a tracker for aged care facilities, and I'm sure Carolyn Hullock, who's going to talk shortly, will provide advice on other aspects of the aged care sector. And finally, can I again reinforce that Health Pathways is the source of the most up-to-date information and is being refreshed as changes are made at a Commonwealth or state or local level. Thank you, and I hope you enjoy the evening.
Terrific. I'll just check you can hear us fine there, and that's a thumbs up. Tony Merritt here. It's lovely to be back on the 4th of these updates, and terrific to be joined by some new people. We'll give an update on, brief update on EPI, both local and international, and then move to some new topics. So Mark Lowenthal, great to have you with us. So the lead on the Hospital in the Home project and Director of Immunology and Infectious Diseases in Hunter, New England. So some new content there, and Carolyn Hullock, fantastic you could come along, and we'll be moving into content around the aged care space, and Carolyn brings her expertise in emergency department medicine, of course, as well for your questions. And John Ferguson will be back again by popular demand. You'll be sad to hear that Kat Taylor can't join us tonight, but she's on a promise to be back in a fortnight's time, so thanks for bearing with us. As always, we'll have some content now, and then we will spend the rest of the evening doing our best to respond to your questions. So Slido's open, PHN4 is the code. Please jump on now, vote up the questions you're most interested in. And without Kat, we're relying on my eyesight to pick the things that are most topical. So if there's something that's close to your interest, vote it up and we'll certainly focus on them first. Terrific. Well, look, that is the team. And there again, Slido, PHN4, please jump on with your questions. A little bit on EPI, both global and local. I've included there the screens. It's extraordinary. It's just 2 weeks ago, and you can see the way the international situation has changed extraordinarily in just 2 weeks, up over 1 million cases, of course, with I think it's 5 countries on the leaderboard above China's count now on the left there. So we've been watching that with a mixture of fascination and horror, of course, as that's unfolded. And last fortnight, we looked at a chart that's a little bit like this. I'll just talk you through it again. I think it helps us in lots of ways. Really important to note that the y-axis there is logarithmic, and so a straight line, the time along the bottom is days since that country reached 100 cases, or is it weeks perhaps? And so it's a logarithmic scale, so a straight line means numbers of cases are growing logarithmically, and that's horrifying. You can see Australia, last time we presented this, it was a straight line. We were in the midst of that doubling every 3.5 days, a terrible trajectory. And Australia started to curve away from that in the same way that we'd seen South Korea had done earlier on. USA still heading relentlessly on a more exponential trajectory. So some promise there for Australia. Obviously lots in the press about the good news there with the curve starting to flatten with numbers slowing. The Sydney Morning Herald headline from the weekend there, Australia on track to avoid a catastrophe. So lots of good news there. And that's a testament to your hard work out there in primary healthcare, finding cases, making sure they're isolated, working with us to find their contacts and making sure they're in quarantine. Of course, that plays an enormous part, will continue to do so throughout the pandemic, many months to come. But the social distancing efforts, again, which we've all contributed to, seem to be having a really material impact, really important there. And I've got a chart here, the flu tracking data. I know many of you will be flu trackers. If you're not, this is a great season to contribute to this community-based influenza-like illness tracking service. Some extra questions this year, COVID related. And that short, sharp, dark line on the left for 2020 is what's happened to rates of influenza-like illness, so cough and fever, since the introduction of those social distancing campaigns. So we believe this is a real measure of the impact of social distancing on ILI at a community level, and we'll watch how these figures travel with great interest, and that's something that's happening across communities in Australia. So social distancing having a superb impact. Going forward, we know that adequate testing is going to be a really key part of the strategy. Australia's doing quite well on that front, on that leaderboard. Australia up there behind South Korea, who's tested extraordinarily. So we can be proud of the amount of testing that we've done. Clearly important that we ramp that up further. We'll talk a little bit about testing in hotspots, and Carolyn might proudly recognise a picture of her drive-through clinic at Belmont Hospital, one of the many services that is helping keep numbers through, and by all means talk to that later as well, Carolyn. I know there's a particular interest in local epi. For our colleagues from the Central Coast, we appreciate that you would like more Central Coast content. We're working hard on that and hope to have a Central Coast rep here next time we meet. It might be a fortnight or so. John's nodding his head. So I apologise, this isn't Central Coast data. I don't have governance over that or access to it easily. So this gives you a snapshot of what's happening locally, but I think it is reflective more broadly across New South Wales. So the chart on the left is a cumulative count of cases in orange. When we met 2 weeks ago, there were just 30 cases in Hunter, New England. We're sitting about 250 now, but again you see that satisfying drop off in the rate of accumulation of new cases. And it's hard to see, but the blue down the bottom there, they're the cases in Hunter, New England that are locally acquired without a recognised source, and we're all particularly interested in those, of course. So we assume that that represents transmission in the community to cases. We look extremely hard at those cases, trying to find areas where there may be transmission occurring and things that we can intervene in. That total is currently 16 out of the 250. The table on the right, little snapshot of cases by age group and gender. And the key age groups 20 to 29, and that's something that's seen right across the spectrum, Australia-wide and internationally. We've got quite a collection there in the 60 to 79 age group. A lot of those got off cruise ships about 2 weeks ago. We were just talking about that may well change over coming weeks. So this is and you'll notice there's none in the under 10, very few in the under 20 year age group. So this is not a disease of very young people. That's playing out here in Hunter, New England as well. And that age group, 20 to 29, are going to feature in the epidemiology going forward. And it's why it was so critical for the social distancing to target pubs, clubs, hotels, and get that group with less contact with each other. So that's a little bit more on local epi. It's a busy chart, I apologise, but I guess the message from the LGA counts on the left is that we've got cases right across Hunter, New England, and we should expect people with COVID-like symptoms across the district in the months ahead. The map on the right is all of Hunter, New England. There's two red dots there, two hot areas, if you like, and so this reflects our efforts to triangulate those locally acquired cases without a recognised source. So there's been a hotspot around Taree with about 4 cases there, unrecognised source, and then again in that eastern Lake Macquarie region, so particularly Belmont, Valentine, Crudis Bay, Windale, Mount Hutton. So in both of those areas, we've in the last 2 weeks promoted additional testing. Carolyn's drive-through clinic at Belmont Hospital has been, I think, fully booked for a good couple of days now, reflecting that activity. So there'll be more of this in the weeks and months ahead when we recognise areas and really need to focus additional testing at those sites. Now, the good news is testing numbers increased quite substantially in both places, and we didn't detect any additional cases on the basis of that testing. That's reassuring. But more of that coming. And I just kept a note in, while we've had a few aged care facilities involved with staff infected, there's been no transmission involving patients to date. That's great news in Hunter, New England. We've dealt with current recommendations in the past. As always, as we said right at the outset, identifying cases, isolating them, finding their contacts, putting them in quarantine, that continues to be the key challenge for us all involved going ahead. Testing criteria, just a few minor changes. I won't go through everything here. Please use the New South Wales Health website as your source of truth here. It does change from time to time. The categories you're used to, so acute respiratory infection with or without fever, fever alone. In any of those groups, obviously close contacts, travellers, anyone off a cruise ship, any healthcare worker, they're all key targets, any aged care worker. Obviously, we're all concerned about vulnerable settings, aged care, but also military, boarding schools, correctional facilities. So potential cases in any of those facilities ought to trigger your interest and have a very low threshold for testing. That will be supported. And in the latest release in these guidelines from New South Wales Health, an intent that anybody who's been referred by their GP or public health unit to a COVID testing clinic will have that referral completed with a test collected, and that clinicians who form a reasonable suspicion of COVID, that's a reasonable indication for testing as well. So again, this is part of a deliberate strategy at the New South Wales Health level to appropriately broaden testing to areas where the either risk of consequences is higher or the prior probability is higher. Okay, as always, if you're testing somebody for COVID-19, really critical that they then self-isolate until that result's available. Some people will need to stay in isolation for an extended period if that's triggered by return travel, close contact, but for others it'll just be until the result's available. Testing options. Now the Hunter New England sites are going very strong. John Hunter, Maitland, Calvary Mater, Belmont we've mentioned, drive-through clinic at Manning. So for both the Belmont and Manning drive-through clinics, really important to ring ahead. It's an appointment-based system. They do get booked out. It's not just a turn up on the day. Fantastic service there, and we heard from John about the PHN-led centres that are on the way. The test collection, so the swab is unchanged, so a single swab oropharynx first, so both tonsillar beds, back of throat, and into the nasopharynx for COVID testing. There's one question there already, I believe, about testing for other pathogens, and that has almost all been turned off to preserve reagents. So we're testing for COVID-19. There are some triggers for looking for influenza and other pathogens, but that early routine where we were doing an R14 or equivalent panel looking for a range of other pathogens is largely turned off to preserve the reagents. All right, I guess we've mentioned a little bit, and John and Mark might like to talk more to the PCR testing in moments ahead. But I would just say our experience has broadened enormously here, and the tests are complex and they're evolving. There are a whole range of different RNA targets that are targeted by tests at the different laboratories. The labs are often using different targets. And the takeaway that I'd offer to you is to be very much beware of results if they're characterised as inconclusive or indeterminate. And we've certainly had a whole range of people who've fallen into that category and have had subsequent testing, and the overall decision has been that they don't have COVID. So take care if there's doubts over the initial test. Certainly, we've talked about false negatives in the past, but in this kind of environment, a false positive is also possible. And then I think the last little section I'd touch on is just the whole issue of release from isolation. So our colleagues in the police forces have been really active. We've spoken to lots of cases in isolation who've been visited by police to ensure that they're honouring their commitment to home isolation. Similarly, for some context, so police are getting that information from New South Wales Health. So it's really important that we let our patients know that that's the case, that they may expect a visit, and it makes that process at the end of releasing people from isolation critical. And so providing a certificate that the isolation periods formally come to an end is a critical process so that they can navigate the world outside their isolation and quarantine safely without interruption. So that's fantastic support. We talked about the criteria before. They're straightforward for some, complex in others. For most of the patients out, in time we imagine general practitioners will play a really critical role in formally releasing people from isolation. We'll make sure these guidelines are clearly promoted. They're in the pathway that we'll talk about more a little bit later this evening. But for people who've had an uncomplicated course with mild illness, who've not been into hospital, the critical timelines are 10 days from onset. That's the first they can be released from isolation, but they need to have been symptom-free for 3 days at that time. If they still have symptoms, their time in isolation continues until they've been 3 days symptom-free. Healthcare workers are more complex, and the public health unit will maintain their role with releasing healthcare workers, just so that we navigate that complexity carefully. They need currently to have 2 negative PCR tests. Terrific. And with that, I will hand over to Mark. I offer you a carefully touched.
I'll gel my hands. When I hand this one over to Carolyn. So thank you for inviting me to talk. I'm the Director of Immunology and Infectious Disease at John Hunter Hospital. I want to talk briefly today about hospital in the home for COVID patients. The model of most hospital in the home up until now has been that someone comes to visit the patient in the home and supplies services that would otherwise be done in hospital. We are thinking of the size of our area and potentially having a large number of patients, and we've actually in the process of developing a new model of hospital in the home, which involves mostly assessment over the telephone or some other communication device, video conferencing, rather than actually visiting the patient. That's way we'll be able to cover a lot more a lot more people and preserve the PPE. We will hopefully take receipt of a large number of pulse oximeters on the 22nd of April, and we will have to reprocess these as well, so that to sort of follow the patient's journey. Once they have had a positive diagnosis, we will want to keep track of them all the way until they're cleared, they're back to their GP, and the first step will be risk stratification. So if 80% of patients are going to be okay, and we'll hope to find GPs for most of those people, and we'll hope that that most of them will have a fairly clear course and be looked after by GPs and cleared by the GP, or in the case of a health worker, we might involve public health still. I'm not certain about that. Yeah, that's still. Can I add that we have submitted our first lot of pathways, so they've been signed off. I'm not sure if they've actually arrived on the pathways. They have? Great. Some of these may change on different days because they're in a state of flux. You may look at them today, they might be slightly different tomorrow. And the other things that are in a state of flux is which areas we're going to cover. Greater Newcastle is quite straightforward, but as far as other areas in the district, that's still a matter of negotiation at the moment. And what's more, other areas like Armidale have got their own, have taken their initiative. We're having yet another teleconference with the Armidale people tomorrow, actually, to see what they're doing. So risk stratification, but of course there'll be some people who we've got it wrong. We'll have a call centre for people, for GPs in particular, say, I'm worried about this person, I'd like them to get on the hospital at home program. That will be fine. We'll follow them at least every day. We've got a series of questions, some sort of systematised way of looking at shortness of breath, activities of daily living. We've got their pulse rate and their oximetry, hopefully. On the figures, perhaps a third of those people, perhaps a quarter, will actually have to go to hospital at some stage. We're working on streamlining those visits to hospital, basically to avoid the emergency departments if at all possible, so that they've already been selected and they'll have some way of getting straight to the COVID area in a designated hospital. So we've got we're putting together a team of experienced doctors. They're not all respiratory doctors or infectious disease doctors, but they're people who are very experienced in the medical system, who hopefully you'll have the confidence in when you talk to them at the next stage of referral. And the next thing will be getting the people who've been to hospital back, and automatically, if you've been admitted to hospital, no matter what your pathway to hospital, I think it'll work out. The first step will be you'll head back on the hospital and the home program. Some people might need extra work and actual physical visits. We're working on that as well, because there'll be old people, the same people whom we see with their pneumonia, for example, and getting them home needs extra work. I think Carol will probably talk about that. And we don't want a back and forth process. And in the end, we will clear some people ourselves, issue a certificate of clearance if they've ticked enough boxes, or on the other hand, if there are people who've got persisting symptoms but have come good again, they'll be back to their GP. That's it from me. I'm sure you'll have questions afterwards. Thank you very much.
So I'll just summarise and make sure, Mark, so it'll be a district-wide, so it's Hunter New England. Again, it's a focus on Hunter New England, that we can offer at the moment. So it'd be a district-wide service with a single point of access for us, both from the public health unit and from the general practice primary health care community. Yep.
That's right. So there'll be a single point of access. A team of senior doctors will be the same for everyone.
Yep.
There'll be a roster for them, unless there's someone particularly keen somewhere else.
Yep.
And as for the nurses and the pods of people making the calls, that's under negotiation at the moment. There'll certainly be a central area, and hopefully there'll be people in the districts. But we don't want people we want some teams of people who build up some experience over the time, rather than have some small hospital-owned service who only gets to see 2 people. So that's the aim is for a district-wide service. Yeah.
Superb. And I've got to say, just to add the public health unit experience, it's been just superb. So we're early days in this, but we've had some really sick people. We've had people we've really been very concerned about at home, older people off cruise ships and elsewhere. And the capacity to assess people in their home and provide that level of support has meant a lot of people, it's really, I think, been very effective at keeping people safely at home. And there's been people brought in where it's effective. And I know that will be attractive to general practitioners, so there'll be a much bigger role. That'll be part of what we talk to in a little while about supporting general practitioners to take a bigger role, looking after your own patients in the community with COVID. There'll be much more of that, and it's superb to have the hospital in the home service as a backup in addition to acute hospital admission when that's required.
Right. Yeah. We've got 13 people on today, I think. Which doesn't sound like that many, but we've had, and I think we've had streamlined referral to hospital. We've avoided people ending up in the emergency departments and getting the same job done twice and 3 times. So hopefully we can get that done across the district over time.
Yep. Yeah. No. Well done. Now, did you have slides you wanted?
No, that's okay.
Yep.
They don't say anything. They don't say that much.
No.
Flick through them.
There is. They're just on the. Yeah.
What are we going to say?
Would you like to talk to that one? Just start. We've had a few questions about. We've heard about ACE receptors being a potential target for coronavirus invading respiratory epithelium. Contrary opinions about whether they're exactly what role they play. So I guess the question we've been asked a lot is on the phones is, what should I do about ACE inhibitors? So somebody who might be already on an ACE inhibitor for their blood pressure or other cardioprotective reasons.
So I think it's also, I think the thing that's raised the attention of everyone is the fact that hypertension does seem to be a risk factor for progression. And people are questioning, is it hypertension or are those people on ACE inhibitors? The receptor is an ACE inhibitor. It's different to the binding site for our ACE inhibitors. Look, everyone has their hypothesis as to whether that's going to make it better or worse. But we do know that hypertension is a bad thing and that ACE inhibitors work well. And the recommendation really across the world is, for the moment, keep people on their antihypertensives when they need it.
Yeah, and it was great to see this consensus statement, I think just out the last couple of days. It just appeared in the MJA, so an Australian consensus statement. So kind of summarising that. If you're interested, there's a lot more detail that's available online, of course, MJA, and something similar in JAMA. So thanks, mate. All right.
Thank you.
Would
you like?
And then John's joined us. We have to work out what works best.
Would you like to swap with me?
We'll swap in a moment. Join for questions, yeah. Terrific. So, Carolyn, yes, have you got a...
Yeah, I'm right.
We've got
slides either. So my name's Carolyn Hullick. I'm an emergency physician. I work at Belmont Hospital. I'm happy to talk about the Belmont COVID clinic if people have got questions. I'm also the chair of the Australasian College for Emergency Medicine in Geriatrics, so if there's questions around ED and geriatrics, I'm happy to answer. But the main reason why I'm here is I'm actually the clinical lead for the aged care emergency program that some of you will know about, which is around supporting the nursing home staff, particularly around hospital avoidance and managing acutely unwell residents in aged care facilities. We're working really hard with the PHN and on trying to get some systems in place in order to keep aged care facility residents safe. And there's two major studies that have been published with the aged care facilities, around 30% of the residents dying when there's a major outbreak. So it's going to have a significant impact on both hospitals and aged care facilities if we can keep all those residents safe. We're working on oxygen plans, we're working on medication plans, palliative care plans, and GP support as well. So I didn't really want to talk in too much detail, but I thought I'd let you know that that's the work we're doing, and we're very grateful for all the support we're getting. And I'm happy to answer questions about it, but also we wondered about whether we should have one of the future webinars to go into more detail around what we're doing.
So yeah, just to reinforce that, I think there's a question there on the evaluation. You'll have a chance to indicate how that fits into your interests down the track for a future webinar that could be dedicated or given over predominantly to that subject. And we'll also take the chance to send through aged care related questions tonight. Well, we've definitely got Carolyn in the room, so thank you so much for coming. So in terms of how that kind of information will be shared in coming weeks, I know there's a lot happening just at the moment.
So we're working closely with the Health Pathways team, and they've been updating things as we've been doing them. There's also a separate ACE section of Health Pathways that's more written around the staff in the aged care facilities than the general practitioners, but we're working hard to make sure that they're interlinked and cross-referenced rather than saying different things. So I suppose that's one way. And there's also mail outs and email groups that we've been sending details to as well. And the two main GPs who we've been working with is Jennifer Briggs and Charles Robinson.
Great. Okay. Carolyn, thank you very much. We'll come back, I'm sure, with questions about both those areas. So I think the plan now, John, did you want any time to talk to infection control issues that are breaking? We've got one more presentation about the PHN pathway. No? Excellent, we've got plenty for you coming. Indeed. Yes, we'll swap Joe in. Joe, would you like to introduce yourself while we're getting the computer set up?
So my name's Jo Wood, I'm a GP and I'm a clinical editor for Health Pathways. Over the last few days, maybe 9, we've been working with Hospital in the Home and with the Public Health Unit to try and map what the next phase of this pandemic is going to look like for general practitioners. I'm sure everyone's pretty familiar with the setup for a health pathway, but we have an assessment section and a management section. I think of particular use for GPs is understanding that now patients that are confirmed positive COVID-19 patients are going to be allocated to a stream. We're having trouble getting the pathway.
Pause for a moment to make sure you're actually seeing this. So it doesn't look like it has come up on the transmission screen at the moment. I'll just move that back and go through.
I can talk about the assessment while we're getting that one up. So at the moment we've made a rapid transition to telehealth in the general practice community. We anticipate that monitoring positive COVID-19 patients will be using telehealth in the main. So the pathway is about doing a useful assessment, looking at how to assess respiratory status and looking for clues to deterioration. We've also incorporated in the assessment how to consider examining patients if they have to come into the clinic. And so there's some tips around limited examination technique that way as well. So if we can get up the streams, for me it's been helpful to sort of conceptualise that the public health unit gets a positive COVID-19 patient. They then determine at that point, Tony, feel free to jump in if I'm getting this wrong, that they will be allocated to the appropriate stream. So it'll be nice and obvious usually which patients will fall straight to hospital, and potentially won't even happen for you. They'll maybe even possibly already be in hospital. But then the next part is working out which part of the community this patient will be most safely managed. So we know that 80% of patients are going to be pretty fine, and they're the ones that we're anticipating will end up with us in general practice. That is a space of uncertainty for a lot of general practitioners, because we have for a long time been anticipating that we will be taking over the care of a lot of these patients. So wanting to know, how closely we need to monitor these people to be picking up signs of deterioration has been a source of anxiety. But the reassuring thing about these streams is that most of those ones that really need that proactive monitoring are going to be captured by HIF. So, and that's the specific HIF COVID-19 program that we've just heard talked about, which will be...
So HIF, hospital in the home, everyone knows that?
Yes,
yeah.
hospital in the home, just to be very clear. That said, so the people that are going to come to us in general practice will have, for the most part, hopefully very limited need to contact, to have sort of regular follow-up with us. The thing that all patients should know is what to look out for monitoring themselves, what will trigger a trip to the emergency department, and what would trigger a telehealth appointment with their GP. And then there will be those patients that we have catered for in the pathway, thinking that GPs probably will want to have some level of oversight, not as frequent as you would need in hospital in the home, but given some parameters around, patients that, especially patients with social risk factors or mental health difficulties that we anticipate will need some support to be able to successfully maintain isolation. So having some plans around regularly checking in on those. With the understanding that at the moment we're in this grey zone, we're doing some good work with flattening the curve, so the numbers are quite manageable. But if it does tend to escalate, then we need to have some planning ahead, which hopefully this pathway will allow GPs to sort of start thinking about, okay, this is where I need to, put most of my work into. And I think really the bulk of it will be in clearing people from isolation. Is that a fair summary of the streams?
Sounds great. And so it's happened in amazing time. Has there ever been a whole pathway put together quite as quickly as this?
So I should probably emphasise that this is a beta pathway. Yeah. So there's a term that's evolved, I think, in this pandemic called living documents, and I really think this is a very good example of one of those. So we've tried to think through some of the scenarios that GPs are going to be thinking about, but we really need this to be a GP-led document. So there's a feedback button on the pathway. If you don't think questions are answered by this pathway, you need to ask, and we need to find out the answers. I think that's the really important part of this. It's a great example of collaboration and working and finding solutions on the go.
Look, and from that point of view, we're putting it out there knowing that there are things which will change here for sure, not just evolve with the outbreak, but how we know will be a best response. So, yeah, we similarly echo that invitation for feedback and just reinforce that this is going to evolve quite a bit, I think, just in the next week or so. But that's amazing to have it out in beta live for people to see. It's a great resource already, I think. So superb effort from lots of people working non-stop. And but it will change, and just my will changes in time as we get better. So we will also increase the volume for you. There we go. Thanks, Todd. Joe, anything else pathway-wise?
I think that just emphasising that it's really, we're not going to have thought of everything, but we've got an amazing collection of brains out there. I think there's over 1,000 people listening, so I'm sure we can come up with some good solutions, and we're certainly all pulling in the right direction of active case finding and supporting patients to maintain successful isolation. So
there's a couple of things I just reflect on. I think that whole area of this deterioration, what to do and where to go. That's just a golden resource. I know that will grow.
Yes.
We recognise the public health unit that we really need to get a lot better at connecting people in that community-based care stream with their general practitioners. So all right, we just need to fix that up so that it's transmitting. I'm back connected. So just recognising that we need to get those systems at the public health unit level for connecting patients and their GPs better. So this is a fantastic step in that direction. Again, welcome the feedback. And that whole area of dealing with people at the end of their period of isolation, of the clearance, again, that's a process we're still working through. One thing I'll flag is that we definitely see GPs being involved in doing that, but it is an area where we'll need to get some feedback when that's complete and know that people have been released from isolation. We'll formally include that in the state notifiable range of issues. Now, I'm still getting messages. Hopefully that is... How is that now? So, terrific work. Thank you very much. So I think that brings us to, we promised kind of short, sharp presentations and lots of time for questions as always. Kat will be sorely missed at this stage. We have got plenty of time, and thanks for voting up key questions. So we might sub back in John and Mark. Joe, thanks very much, and we'll grab you in a moment for extra questions. Well, look, I think we can manage one more chair here. If people are happy. Do you want to just pull that to the... And...
Hi everyone, while we're doing a bit of a swap of the deck chairs here, I just like to address the concerns of clinicians on the Central Coast. We are working with Central Coast Local Health District to get local health district information out. We're also endeavouring to have someone from the local health district on the Central Coast present at our live updates. Unfortunately, they've had a change in key personnel over the last week, which meant that they were unable to have someone here today, but we will make an effort to work with the LHD to get someone here for the next event.
And John Ferguson, welcome to the group. Thank you once again for coming. The question time is indeed your special section. I appreciate it. I think you completely dominated that last time, and we appreciate it.
Perhaps I could presage. I've looked at some of the questions, and I'd presage by saying that really infection control advice hasn't changed. The WHO is still evaluating evidence and is firmly in support of droplet and contact precautions for healthcare workers, and they do that because of good level of evidence on how this virus transmits. It doesn't transmit by the tiny droplet nuclei that are so important in measles and tuberculosis. There's no evidence of droplet nuclei spread. So we, in essence, don't need to be very concerned about whether we're using a P2 or a surgical mask. We just need to be using a mask, and the evidence is that either mask is going to provide you with the necessary protection for those droplet precautions.
Yep.
So we can talk about that more.
Indeed. And in terms of now, we've got some kind of hands-on experience with managing COVID in Hunter New England hospitals. Have there been lessons or in terms of that kind of fundamental infection control messages now born out of direct experience?
Look, I think people are getting practiced with the business of putting on the PPE and taking it off safely. That's really the long and short of it.
Absolutely. In any setting, general practice as well, of course.
I guess the tension for us has been a lot of the left field stuff coming in from other expert groups who want to weigh in, whether it's an emergency college or a college of anaesthetists, etc. And so they're providing slightly variant advice to their membership who then get anxious and want to do different things. And so there's been that tension. I think one of the questions was around, are we to the stage where generalised masking is an issue, and I would say we are not. I mean, this is really a public health call, but we would be waiting for a situation where we have a lot of undisclosed community transmission, so that you can't really distinguish who might have COVID versus those who might not. I guess the long and short there is that we should be relying on standard precautions, pure and simple, so and understanding standard precautions around risk-assessed use of PPE. So you're seeing someone to examine their throat, whether they've got symptoms or not, you wear a mask and eye protection, something like that. And certainly there's triage arrangements in most practices now to distinguish patients with respiratory infection who are likely to present, and you've got mechanisms to control that. So even the reception staff don't need to be masking up, I would say.
And we've got the physical distancing elements that we're all getting better at practicing. It's terrific going shopping now and seeing, the Baker's Delight getting the physical distancing just right in a way that was unthinkable a month ago. So I think there's a level of protection there. Similarly, we just echo the sentiment completely in terms of widespread mask use, that we're not at that stage. But Carolyn would like to comment, please.
Yes.
I'll join in. I suppose working in the ED, there's two things that I've been thinking about. I agree with John. I think the community levels are not high enough for it to be a major risk. But I think the clinicians have to get used to working in PPE in order to be able to be safe in the job that they do. So I kind of think, I've been saying to at Belmont, you can wear a mask if you want to, it's not mandatory, but in a couple of weeks' time it's likely that that'll change. Because I think we have a very procedural kind of job, and if you're not used to having gowns and gloves and masks and goggles and everything on, it's actually quite dangerous to do that at the peak of COVID. So I suppose that's the kind of counter argument around wearing masks in the workplace. And then the second thing I think that's really important around donning and doffing that sometimes people forget is actually around having a buddy. Yep. So in the ED we've worked really hard on any time anyone's donning and doffing to have a buddy who's pulling you up when you're not doing the right thing.
So just talk us through what the key role of the buddy is?
So to actually properly don and doff everything, there's quite a few steps and different pieces of equipment that you need, and there's a process that you need to follow in order not to contaminate yourself. So the role of the buddy is really just to check up on you and say, oh, you just scratched your nose, or you've put your gloves on before your goggles, so go back and do it again. So, because it is actually quite difficult to don and doff properly, even if we've practiced in doing it every day. So I suppose from my perspective, training is important, but having a buddy is actually more important.
And that's an ongoing thing, I think, Carolyn. So because I think that where people have slipped up in the past, even with excellent training, is you get tired or you get rushed, and then
it's urgent, and there's someone who's really sick, and everyone wants to rush in. So the role of the buddy is to actually pull everyone up and say, hang on, stop, you've not put that on, or you've forgotten your goggles, or you haven't put your whatever.
Terrific. Okay.
Yes, it's been a very good idea, to do that. That's what we're doing in John Hunter as well. Yeah,
but it's how I suppose if you go back to when you have very formal training on donning and doffing, the principle is that you should be doing it with a buddy anyway. So we're just asking people to do what they should already be doing, but maybe we've been a bit more lax on recently.
And I think, as you say, the risk assessment that the clinician individually makes with the patient can dictate additional PPE that they want to use, and that's certainly fine as part of standard precautions. It's just we're not recommending generalised droplet precautions yet.
Yeah, no, I agree.
And that's the same in general practice.
Now, the most highly voted up question is a variation of this, but in delivery of the flu shot. So what personal protective equipment should GPs and nurses wear while administering the flu shot, and particularly is a gown essential? So gowns are a topic that we've touched on and off over the time. Would you care to comment, John?
Well, I'd presume it's an asymptomatic patient coming in for flu shot, so really all that's required is the usual standard precautions. I wouldn't be masking. And you can certainly sit with a patient like that and not actually sit face to face, so that it's just ways of organising your clinic so that you minimise that face to face contact, which is important.
We had a question about a drive-through flu vaccination clinic 2 weeks ago, and I know there's been some of those set up. I'm not sure whether in Hunter, New England, but certainly elsewhere in Australia. So there's some really innovative approaches to keeping those streams of people separate.
Some of our rural GPs are working outside. You know, they've got clinics completely outdoors. We've learned about those.
Nice, isn't it?
Yeah.
Good for your vitamin D.
Indeed. Carolyn, this question's coming to you. So copies of results for patients tested through hospital testing clinics.
Oh my
Can
goodness.
a copy to the usual GP be added to request forms?
So this is a very frustrating question, I know, for everybody. So with the imaging now for Hunter New England, all the process of adding the GP to all the imaging request forms is automated because all that data is actually collected when the person's registered at the front desk. But unfortunately, Auslab's not quite as 21st century as some software programs, so it has to be done manually. And it doesn't quite fit in with the ED workflow. So because we often, the stickers don't, the stickers that we have the patient's name, but they don't have the GP's name on them. So it is actually quite a lot of extra work at both the lab level and the ED level to put them on. But we have been in the drive-through clinic. But I also know the New South Wales Pathology today, I think, has finally gone live with the COVID results being SMS to the patients.
Yes. Yep.
So I think that's going to take a lot of it. I saw a lady in the emergency department a few days ago and she'd come off a cruise ship. She'd had a COVID test. I think she'd just been to Tasmania. She hadn't actually even been overseas. And she'd been waiting 11 days for her results and she came to the ED with chest pain. And a lot of it was really anxiety around no one ringing her. I said, well, it's actually good that no one's rung you. It means that it's probably okay.
Yes.
But she's still sitting at home in self-isolation and it's a massive deal to her and her family.
So I know the clinics are trying to capture general practitioner, but clearly that's not working.
Well, it's a manual process,
uniformly.
and
that's right.
I suppose it's the reason why I'm frustrated by it is that we have all these electronic systems running around and we're collecting all this data, yet we're asking busy people to go and manually enter it, and it just seems like a crazy system. But one day we'll aspire, and it's encouraging that imaging has fixed that problem.
Carolyn, thank you. Mark, can I put you on the spot about point of care antibody testing? So it's a question that comes up from time to time. We're hearing about the point of care tests looking antibody testing is the question. So
you can, but I might put John on the spot for that. What I think.
Look, and there's been a lot of fake kits being marketed in third world countries and creating an enormous bother. So, and they're being very persuasively marketed to governments and so on. Look, the basic concept is that these tests are not worthwhile. Yes, there is an immune response that you can measure, but in the acute presentation at day 1 to 5 or so on, they are not sensitive and they don't have a role in diagnosis. We believe the PCR is probably a bit more sensitive if used in those initial days of illness because this virus has high viral load early. The SARS virus in 2003 was a virus load that was later in the piece. It probably helped us with the control, I guess. And a lot of the initial information on PCR for this disease came out of hospital studies looking at patients who had presented at 7 or 8 days to hospital worsening, and so their PCRs were not necessarily positive from an upper respiratory sample. So the PCR is still the way to go. No approved point of care tests yet.
So it's enormously seductive from a timeline point of view, but I know, so RACP I think has a position statement on the antibody test that no role for acute diagnosis, no response reliably before about day 12 I think was in their paper, so kind of sobering warning to steer clear of them, certainly in terms of acute diagnosis. Serology comes up from time to time for us, and so I might offer that is available, but it's quite restricted. So at the moment, for us to get serology through, and I'd be interested in your experience, involves us actually making direct contact with the lab and making a public health argument in terms of understanding transmission chains in epi or better understanding interpretation of tests. So we've got a small handful of people in whom we've got serology requests in. It goes to Westmead, ICPMR, paired sera 14 days apart. Has there been any experience with serology yet in health service locally?
No, we're just discussing about that exposure event in Manning from a month ago, going back to test those healthcare staff that didn't acquire COVID and look to see whether they had subclinical infection.
Our feeling now is that that's going to be the role.
Yes.
That may change, of course.
Yep.
And someone might develop an antigen test as well, but that's not the case. The case now.
And there's some work looking at getting a better understanding about transmission risk in schools in Sydney and potentially locally. So again, that's collecting sera for antibody studies, looking for evidence of unrecognised transmission in school, given particularly that kind of initial flurry. So we'll have more information on that.
Yes, as an aside, there was some very good published data last week on analysis of clusters, household clusters across the world in a number of countries, and showing that children were usually not the index case for those clusters. It was the older adults, and this is quite different to, say, influenza, where influenza is often brought into a family by the child. And so undisclosed children carrying this virus don't seem to be a major part of the transmission chains.
So we steered away from the school closure issue last time, but I can't see any reason we shouldn't charge straight into that, because it connects with this issue at least at one level. So we've got young children we saw in the local epi with no one under 9 infected so far. That's a small data set, of course, time to expand. And we're not seeing young children involved in transmission chains frequently, infrequently, if at all. So I think they're the two main threads that play into what is a rational discussion around schools being open or closed. And that point you made, John, about this being just fundamentally different from influenza. If this had been an influenza pandemic, we would have been jumping up and down to close the schools as the earliest step. But you saw that age breakdown with 20 to 29-year-olds, much more sensible to close or change the way universities operate than to close schools, primary or secondary, just driven by the epi, and it's a different condition. Okay, so we've covered off quite a bit on PPE. I think we've covered, so no recommendation for members of the community to wear masks. Anyone like to comment about cloth masks versus surgical masks? I was listening to news out of the States, of course, very topical at the moment, with an encouragement for people to voluntarily wear cotton masks at a community level.
Yes, so there's a vast range of masks being produced out in the community, including ones made out of vacuum cleaner bags and other sorts of material that are a bit better than cotton. Look, I think they're definitely inferior to our masks that are available in hospitals, and we don't want to be using them in healthcare or in general practice. Certainly in the community, they're a good way to confine a cough or a sneeze and reduce contagion in that manner. There was some perhaps troubling data, or it wasn't really new data, looking at how far droplets can spread from people, potentially much further than the 2 metres. Really a paper that was sort of musing on, it didn't really have a lot of data to speak about, and it was more just an anxiety-provoking paper, more than anything. I don't know if you saw it, Mike. I think it was a paper looking for relevance, really. And I've seen another paper suggesting that masks are not entirely successful at containing aerosols from coughing patients, but certainly they have some effect. There are data.
Yep.
So I wondered if they had an effect from stopping people from touching their faces.
Yes, well that's something.
Whether that might be a positive impact of masks.
I think when cotton masks get wet, though, they lose their efficacy straight away. So the key thing is to have dry masks and to wash them frequently.
Thank you. I think this question is for me. Can you tell us about the 3 COVID-19 cases in Eastern Lake Macquarie region with unknown source of infection? Well, very in a limited sense, I guess the fact that we're promoting that there are just 3 there and increasing testing talks to the level of kind of sensitivity here. Those were across a short period of time, without links, across a broad range of age groups and across a range of suburbs. So it wasn't any pointier or hotter than that, but enough in the area for us to be interested in increasing testing and looking for further cases. And that's the kind of level where we'll be targeting at this stage. So no more information than that, but a broad range of people that we couldn't connect in terms of common exposures.
I've got a question related to that.
Yes.
This is quite good being here, isn't it?
Yes. Yeah. Be careful, I've got the questions here.
How long will it, at what point would you say we've done enough of that testing and therefore we can turn off that cluster local community testing?
Yeah, it's a great question. In terms of, and we're certainly asking GPs to help, of course, with identify potential candidates, fever and or acute respiratory infection in those areas. Let's make sure they get tested. And at the moment, as you say, it's that eastern Lake Macquarie and in the Taree region. I think we'll generally turn those on for about 2 weeks and then be guided by what happens. If we flushed out a number of cases, obviously we'd expand and continue, but I expect we'll have rolling episodes like this around Hunter, New England, and do that for a couple of weeks and see what happens. Carolyn, complete coincidence, but a question back for you. So what happens if a resident of an aged care facility tests positive for COVID-19?
Well, it depends on the resident and it depends on the facility in lots of ways, but many of the residents are very frail and have advanced care plans that suggest that they don't really want to come to hospital. Where, as I mentioned earlier, we've been working hard on getting oxygen plans for all the aged care facilities, so that if they need urgent access to oxygen, they can get them, and then palliative care. So it depends on the resident, their family, the general practitioner, the aged care facility, and their ability to manage. For me, also the big risk is around the ability to contain that resident within the facility. So if there's only 1 or 2 cases and that person is a patient with dementia that's wandering a lot and invading other people's social distancing space, then there might need to be different decisions made about that person as well. So I think it's going to be a very case-by-case basis, but I suppose the point of hospital is to improve supportive care, and a lot of that supportive care can actually be delivered in aged care facilities. So I'm hoping, I remain optimistic that hopefully we can manage a lot of people within the aged care facility and not need transfer to hospital.
And I guess we're expecting inevitably as this pandemic continues, there'll be outbreaks in aged care and that they'll be successfully managed with patients in situ.
Yeah.
Perhaps this is a chance just to talk about some of the kind of prevention steps that facilities are taking at the minute in terms of trying to keep COVID out and what it might, how facilities might be behaving differently at the moment. Yep. So
with the PHN, we've sponsored a whole bunch of short videos with some education on infection control. It's just about ready to go, I think.
Yep.
We've done a risk assessment on all the aged care facilities across Hunter, New England, and I'm not sure about Central Coast. John can probably answer that question. Particularly looking at the aged care facilities that are high risk, so the ones who are maybe individual facilities rather than belonging to a larger organisation, don't have access to 24-hour registered nurses. So I suppose they're the kinds of things we've been looking at. And then the national guidelines around from CDNA around access to aged care facilities and reducing residents and testing the aged care workers similar to the healthcare workers from a case definition perspective. But really that's what we have to do, because once there's an outbreak, it's going to be very difficult to control within the aged care facilities.
Yeah, so really high level vigilance for potential COVID, early testing. I think anybody with ILI, any resident in an aged care facility testing ought to trigger a COVID test, and we'd certainly be supporting that. Turn them off after 5, like if there's an outbreak, we don't need to test every single person, we can spare the reagents, but so early testing, high level of suspicion and low level of vulnerability, rapidly going onto an outbreak footing. It's going to be key. We will have aged care outbreaks, of course.
So I think we've already had quite a few respiratory outbreaks in aged care already, not non-COVID outbreaks.
That's true.
That's right. So they're extremely challenging environments to keep contained because they're not clinical environments as such. And I think even one case of COVID within an aged care is a red flag, because you won't really know if you've got secondary transmission for 5 to 7 days. By that time you might have a brace of cases and have an out of control situation. So the occurrence of even one case is means you've got to take action there and then. And I would say that you even have to perhaps bring in universal droplet precautions amongst the staff or something. Something has to happen at that point.
Yeah, I think it's an outbreak.
Because usually that case will have been symptomatic for several days, so there would have been scope for transmission, and you're already behind the 8 ball.
Yeah, so I suppose there's been lots of conversations around that. I mean, there's 2 major papers, one from Kings County in New York and one from Washington State, where I think the aged care facilities had around 150 residents, with 100 of them getting COVID and 50 of them dying, and also a couple of visitors and a couple of staff as well. So, so the implications when it goes badly is really terrible.
And sobering that there was very widespread asymptomatic or pre-symptomatic infection. So PCR positive residents were really quite common in one of those. Many of them then went on later over the next week to develop symptoms. But it just goes to your point, John, about a potential for it being actually quite widely established and needing to intervene vigorously. And
I think you've stressed the idea of early diagnosis, so getting on top of it, the diagnosis of those first case.
And then I think the other thing is just around the difficulties of making a diagnosis of a resident with significant cognitive impairment in an aged care facility.
Yes.
That they're much more likely to have an atypical presentation, maybe less likely to have a fever, or their fever's maybe a different temperature to a fit and healthy adult. So I think vigilance has to be is the answer. One of the things I have asked, and we haven't had an answer to yet, it would be really helpful to know what's actually happened in the Dorothy Henderson outbreak in Sydney, because there's 6 residents from one facility that have died. Just to know, I suppose,
just in terms of how it was managed.
What went well, what didn't work, what were the things that were the risk factors, because I suppose that a lot of the literature is talking about the devastation, but no one's really talking about this aged care facility had no outbreak because they did all these things, and that's the information we actually need, isn't it? The opposite.
Yeah.
Fantastic. I think this one is for me. Population Health is not making daily phone calls to COVID positive patients. If they're unable to do this, do we want GPs to do so? So hopefully you get the sense from that pathway that that's absolutely core, and if we're late to this, then I will apologise for that and take that on the chin. Clearly, we recognise a need to integrate much more fully there. We are calling some cases. The system for case follow-up has been through a roller coaster ride since this began, and the statewide system of SMSing was functioning at some stage and is no longer functioning. And so we're calling some high-risk groups. The Hospital in the Home service is managing another group that we've assessed as being vulnerable, and some people are not getting calls. But we see a key role for GPs, and the pathway sets that out. So again, invite you to look at that and give your feedback in terms of how that's structured.
I think another issue has been with that group who had the indeterminate results, and no one really knew exactly what to do, and we had to wait for testing to go back and forth from Westmead, and so some people did end up waiting what must have been a very anxious time. But I think it's a new process. As we go through it, each time we come to a problem, we'll work out what to do next time if we didn't do it perfectly this time.
Okay. Now, there's what's the situation with asymptomatic spread here and overseas? And then I've got a question about masks and aerosol generating procedures. Mark, John, would you like to have a crack at the asymptomatic spread question?
Well, I think it's difficult to know the significance. So different countries and different testing approaches are finding different numbers of asymptomatic carriers. Some of those patients are pre-symptomatic, clearly, or have a very mild illness that follows on. I was thinking that the viral load in these asymptomatics was going to be low, but it's not necessarily low. So they clearly probably can transmit. They'll be contaminating surfaces, and I think the relevance awaits further study. What would you say from a public health point of view?
Look, I don't think we've had an indicator of asymptomatic transmission being a really key issue. So with this conservatancy. Okay, we are appropriately cautious with the infectious period. So 24 hours before onset, we include that period and go looking for close contacts in that time. And so that's exactly this idea of asymptomatic or pre-symptomatic transmissibility, potentially. Haven't seen strong signals for that being an issue, and that time is under consideration. It may even be extended further. We know people can be PCR positive and have virus there before onset, but in terms of its contribution to transmission events, I haven't seen strong signals of that.
And I think the data out of China, the extensive data that came out of China reviewed by WHO, failed to show asymptomatic carriage as being a key to their transmission chains as well.
Yep.
Yeah, and the thing is that social distancing, quarantine prevent cases whether there's asymptomatic infection or there's asymptomatic transmission or not. It clearly does occur, but the significance of it is still to be determined. But the idea that there's a huge number of asymptomatic people out there, that's not true. So I don't know if you saw the Diamond Princess figures. So even though a bit under half of the people were asymptomatic at the time of testing, it's calculated actually probably in the order of 17-18% of them remained asymptomatic. So so if you're following people who've got symptoms and you're following people from a day before the symptoms started, you're probably capturing not everyone, but the vast majority of people.
Yep. Certainly. So to watch this space, but that's been our impression from public health land as well.
Can I quickly add something about the other end? In PCR positivity, so one of the strengths of the PCR testing is that the organism doesn't have to be viable. You only need that little piece of RNA, but that also means that people who are PCR positive at the end of their illness may well not be infectious, and there's small studies with good data to show, for small numbers, to show that that viable virus that can be cultured or can infect somebody else stops a long time before PCR positivity stops.
Yes, we're not really measuring infective virus,
That's
are we?
right,
And we're constrained. Okay. John, I think this is for you. Are N95 masks single use if they're used for aerosol generating procedures?
Right. I'd be interested in what aerosol generating procedures the general practitioner is referring to. But so we can go on using an N95 mask through a session if you're using it to see multiple patients who have a COVID risk. But in large part, our masks are single-use masks. So at the end of the session, they should be disposed. And there are lots of plans afoot to reprocess or sterilise masks. We haven't stepped that far because we have sufficient masks, and I was setting up projects to do that. But and I think the Mater Hospital is continuing with such a project. We also have to think of our Pacific neighbours to the north. I heard from PNG and Timor that they're extremely short on PPE.
Yes.
So I think we should be reprocessing our PPE to send up there, for sure. We don't seem to need to do it, and there's sort of a yuck factor that comes into it. So look, in answer, you generally will dispose of the mask when you've finished with that clinical care episode. So within our COVID hot zones, the nurses will be in there for 1 to 2 hours doing care, and they won't be changing their PPE. They'll just be changing gloves between patients.
Yep. So same gown,
yes,
same mask, same eye protection. Yep. Okay, that's
sometimes they're, depending on how hot it is, I think, they're able to wear it for like 45 minutes, and sometimes they can wear it for a couple of hours. So it depends on how fast they're breathing and how much perspiration and all that kind of thing.
Yep. Mark, are you able to comment? There's a question about the kind of demographics, I guess, of intensive care and acute cases in hospital. Well, I guess you've seen some of them come through hospital and the home. So is this in particular age groups that have made it into intensive care? Are they people with particular vulnerabilities or comorbidities? It's a little bit unfair, but in terms of people you've seen at the higher end of the hospital and the home group?
Look, undoubtedly, if you have comorbidities, diabetes, hypertension, obesity, if you're a cigarette smoker, then you're more likely to end up in intensive care. And interestingly, COPD as an independent risk factor doesn't seem to play out over and above smoking, but I don't know whether that's an interesting finding. I don't know what that will, but that's definitely been the case everywhere, including here. I mean, age does seem to be the most important single risk factor, with an inflection point starting at about 60 or so, and then going quite steeply up until it's in the order of 15% of over 79s, and you can see the high mortality in the nursing home group.
So from memory, I know we've had ICU patients from in their 50-year-old plus, but the most frightening week so far has been when that cohort from the Ruby Princess, who are often in their 70s and 80s, were moving into the second week of illness. And we've said in previous sessions how often it's that second week that's where people can precipitate, they can have been travelling okay, and then fall off a clinical cliff very rapidly. So we had people calling ambulances, we had hospital in the home urgently assessing people, monitoring them several times a day. So it's something for us all to look out for. The pathway reflects this, that vulnerability in the second week in particular, so we all need to be attuned to that, particularly in people with comorbidities and age.
And I know that a lot of the early blogs came through saying, day 5, day 6, day 7, but actually we've seen people a long way further down the track,
yes.
And particularly that elderly population, even into their third week,
right.
I think just wearing out after 2 weeks of being ending up at least in our COVID red zone.
Is it too early to ask whether there's any useful kind of early indicators of potential deterioration in community managed people? Any signs of people tiring or?
I think you'll have to ask that question a little bit later. Although one of our this is who's big sort of 2 people at exactly the right time to be sent off to hospital.
Yep.
She's obviously getting a small amount of feel for it, because also she's seeing, she's sent Drew into hospital, but she's seen lots of people who she hasn't sent into hospital.
So it'll be a really hot issue though, won't it? What strategies can we use to pick up people early enough before they're exhausted, particularly older people who will then tire very quickly if they've been working.
And I think if you look at our assessment sheet, we've got a number of things there that are, if you like, unvalidated, and it's bad in a way, but good in another way. At the end of it, we will have some validation on those.
Yes.
Those things like the so-called National Health 111 assessment tool. It's been put in there, it's been used as in the category, it seems like a good idea at the time, but I think we'll have it validated. Not just us, but groups around the world will have it validated in a little while.
I think one of the things that's actually important for general practice is around advanced care planning in relation to that too. So knowing exactly when someone can tell you what they want and what their expectations are in a couple of weeks, how they want to be managed.
Yep.
Much better to ask them those questions earlier. And I know in the emergency department at Belmont now, when we're admitting all patients, we're doing adult resuscitation plans in order to be able to ask them when they're well enough to be able to answer those questions. And most older people, I think, do know the answers to those questions. I rarely find that they're difficult conversations because they know what they want.
It's a great point, though. This is a good time for people to be, in general practice, to be looking at, having those conversations as well.
One of the things we've been talking about is a scale called the Clinical Frailty Scale, which comes from Canada by Ken Rockwood, who's one of the big frailty researchers. It's actually a really simple, like there's a lot of geriatric scales that drive me crazy, but it's actually a really simple one with really good descriptors in it. That, and basically, I think the British Geriatric Society, geriatricians tend to score patients better than emergency physicians do.
Okay.
Maybe because we're seeing them sick in the emergency department. So from a college perspective, we've looked at a clinical frailty scale of 6 and over, meaning that those patients with that level of frailty are much less likely to be surviving critical care and ICU admissions. So I think better to talk to the patients and have the clinical frailty scale is a good objective measure too when you're having those conversations. So, but better to think about it earlier rather than in the ED when people are wondering about whether we need to intubate you right now. That's not the right time to have those conversations.
Yes, and I think people need to appreciate that once you're on a ventilator with this disease, you don't do well.
No.
Most people stay on the ventilator for at least 2 weeks perhaps, and I think the mortality is very high.
Yeah, I think the best paper I've read has a mortality of 50% on a ventilator, and the worst one was 80 or 90%. So once you're on a ventilator...
So avoiding futile care is really important.
One of my friends is in charge of palliative care at New York Presbyterian.
Oh my goodness.
And I spoke to him last weekend, and it was one of the most distressing phone calls I've had, maybe because I was on the other side of the earth and he could download to how difficult it is. But there's no visitors in New York at all in hospitals, so there's frail old people on ventilators in ICU. He's doing all his palliative care consults over the phone, speaking to families who can't be with their loved ones when they're dying, and he said more people have died in New York than 9/11, and it's going to take years and years for us to recover from that kind of insult to a community, I think.
Yeah, it's just, for me, it's so important to be reminded of how sobering that is. It feels like it's almost too good to be true at the moment. Like we're actually...
Yeah, I don't know if it was good for me to talk to him or not good for me to talk to him.
But anyway. I think, look, I don't think it hurts that it comes up in this context, because I think we seem to be travelling on a very reasonable trajectory at the moment.
But not out of the woods,
But we've surged staff, and we've got people, with quiet time at the public health unit, because we've massively increased our numbers, and we were drowning 2 weeks ago. But that's absolutely right. We've got plenty of challenges ahead, pending kind of widespread vaccine access. So good to remember.
Thought, Mark, with the clinical assessment criteria, the oxygen saturation is quite key, isn't it? Because I've heard that patients don't necessarily...
It does seem to be key, and I know the literature, so...
So hypoxic patients are not necessarily very symptomatic.
No, it's interesting.
Not at all, that's right.
And so you might be surprised by that measurement.
Yeah, look, that's what the literature says, and that's been our experience as well.
Hence a whole lot of pulse oximeters.
So one of the things we've written into the oxygen plan for the aged care facilities, and I'm not sure how successful we'll be with this, but this is what we're asking for, is for them to be measuring oximetry once or twice a day over the next few months, so that if and when a person deteriorates, we'll know what their baseline is, because I think that's one of the challenges, isn't it?
So understanding what you're comparing it to. Yeah, that's a great point. All right, I think maybe this question comes to me. Should the whole family isolate when someone is tested for COVID until the result is available? And generally the answer is no. So if someone's tested, they need to isolate, so they're not putting others at risk. And the only exception would be occasionally we are just so sure that person is going to be a case that we're preemptive, and it might be that we have a high level of suspicion and one of the family members is a healthcare worker. So there's always exceptions, but generally if someone's being isolated while they're waiting for their test result, doesn't have implications on the rest of the family. It makes sense for the rest of the family, obviously, to be separate from that person. That's what isolation means, but not constrained in terms of them going out and about.
Then if they're positive?
And then if they're positive, then we slot into at the well-worn public health track now. So for around every case, obviously really important, they're isolated until non-infectious. We talked about clearance for simple community cases. And then we go through that process of close contacts, and all the close contacts, those who are going to be at high risk of going on and becoming infected, potentially infecting others, then those close contacts go into quarantine
as well.
And we've worked through the maths of that in this group before, but that quarantine period for 14 days starts at the last contact with someone who's potentially infectious. And so the lousy news for people who do a great job staying at home with a home-managed COVID case, but in the kind of contact in the home, is that their quarantine period really only finally starts once the case they're helping support is no longer infectious. So it's potentially a long period of time. Our practice has had 2 confirmed COVID positive patients. Will population health assess, staff, risk and notify? So that fits absolutely into the routine of the process we were just talking about. So that is something we definitely do as a routine. So we're aware of a patient who is assessed to be infectious at a time they had contact with clinical services, general practice, hospital, elsewhere. We'll definitely trigger assessment of that. Sometimes that'll be done in hospital by the infection control team. We'll be in contact with practices if we assess there's a need to look at contact there. Sometimes we can be really clear talking to the patient. We know how long the consultation was. If they were there for 5 minutes, there's no possibility of a close contact. If there's any question, we'll talk to the practice. How many people are working in public health now? Well, it's a big group.
All of us.
And it's, that's right, we're all doing public health. Thank you very much for your public health work. We've taken over completely the building that used to have 80 health promotion people in, so it's a big group. And we have a couple of other sites. So we're planning to be busy for a little while yet. John, this is, do you need a mask if you have full face shields? So I guess that's some of the...
Yes, well look, depends on what your intent is. If you're just using a face shield for droplet protection in standard precaution, really you need a mask under the face shield. The face shield's providing eye protection and perhaps an additional little bit more protection of the whole face. It's sort of the equivalent of eye protection in essence.
Yep.
You know, a related question is, do we use goggles versus glasses or face shield? Because you know, people are again getting worried about droplet nuclei falling on the eye, going along the edges of glasses. And again, I'd say no, that there's absolutely no evidence. It's direct droplet impingement. So the eyewear is designed to stop those droplets firing at your mucosal surfaces.
So not all the way to goggles, but you've spoken in previous sessions about the advantage of getting...
Yeah, wraparound specs. So
yeah.
I've got mine in my bag that I'll show you.
Yep. Just that. So interrupting kind of access from the side.
Yeah, and I think it's a reasonable idea to wear them always in clinical practice. You know? So in the laboratory, we always wear protective specs no matter what we're doing.
Indeed.
So make them part of standard precautions so that when you actually need them, you've got them there and you're used to wearing them, I think.
Yep, and not touching them.
The biggest problem I have is them fogging up. I don't know if you've got any tricks on that when you...
Oh, the wraparound specs?
Well, the safety glasses with masks. Is there any tricks to that? Breathe less.
Well, again, the visors are a good solution to that because they don't fog up. I think having proper wraparound specs, they seal more around the nose so that you don't get the humidified air coming up and fogging them. You can get anti-fog coatings for your glasses too. People swear by that.
Okay, I'm getting messages voted up from within the room, so the PHN will follow up in terms of telehealth and nursing staff in practices. So that's an area that's clearly of interest. We'll get back to you, or the PHN will get back to you in relation to that. Caroline, I think this comes to you. How are GP referral criteria being assessed at testing clinics? I know you can just speak for the Belmont one. Do just need to state that, or is there a need for a letter or request form from GPs?
No. So I suppose our premise is that most of the time people tell us the truth.
Yes.
So if people are ringing up and saying, my GP's asked me to have a test, or public
Yep.
health have asked me to have a test,
Yep.
we've just been testing them
Yep.
because we haven't got the time and the interest in seeing whether that's not the right case. And I suppose most, as clinicians, most people tell you the truth, don't they?
Yep.
It's
And
part of clinical practice.
We're really interested in people who've been filtered by general practitioners and sent to it. I mean, that's a group we just want tested. You saw it reflected in the New South Wales guidelines, and as testing capacity has really expanded, we got some more swabs into the district, just arranged today. And particularly focused around areas of unexplained transmission. That's going to be really critical. Okay, thank you for that. This might be you again. Do we have enough registered nurses in aged care to provide the relevant medication and support? I'll paraphrase.
No.
Is that,
I suppose one of the sad things about the COVID outbreak is that the Royal Commission was doing such amazing things in relation to what we need to do to better look after people living in aged care facilities. Unfortunately, in New South Wales, not all aged care facilities have 24-hour even registered nurses. So things like PRN medications that we kind of take for granted in hospital are not necessarily available in a facility that doesn't have a 24-hour nurse. So no, we don't. But I suppose as part of our ACE program, a lot of it's around capacity building and capability of the nurses and supporting them. And one of the really good things I think is around phoning a friend. When we talked about setting up the model, we talked about whether it should be a medical model or not. But really the aged care, a lot of the aged care workers, not even registered nurses, are the ones who are making the decisions around sending patients to hospital.
Yep.
And they really wanted to talk to a buddy, which was a nurse really. And then the other principle of the ACE program is that there's a doctor backup. So if the registered nurses have a more specific question that's medical, then they come to us. But the vast majority of the time, the aged care facility nurses and the ED nurses actually sort it out together. And the analysis demonstrates that we've had a 20% reduction across the district in aged care transfers.
Yes, that's quite striking numbers about the number of aged care residents in hospital beds at the moment, down absolutely dramatically.
Yes, particularly at the moment there's hardly any, but I think so. I think that we're doing our best, and no, there's not enough. I mean, I could talk about this for days, but the nurses
need another session.
Yeah, the registered nurses get paid less if they work in an aged care facility than if they do work in a hospital. So they're on a different award scale. So a lot of the aged care facilities are employing RN1s who in hospitals have a very good, supervision process within the hospital system, like our interns. And I just find it really difficult that they're, that we're, I suppose as a community, not necessarily valuing those residents, are we?
I think it's wearing another hat as a general physician. I see lots of old people, and healthcare and aged care go hand in hand. I think that's so important, particularly in residential aged care facilities, that there are skilled healthcare workers there, and that again we were hoping, and perhaps it still will, that the Royal Commission will reinforce that.
Yeah.
Hopefully.
I think one of the models that will happen into the future is around the partnership of general practice and nurse practitioners working in aged care facilities. So the nurse practitioners being more facility based, who are working with a GP. And I suppose again from my work in the United States, that was a pretty common model, that the patients had to see their GP. Those regulations had to see them at least once a year. They had to see them after they'd returned from hospital, and they had to see them anytime the nurse practitioner wanted them to. But the kind of day-to-day issues were actually managed really well by nurse practitioners. So I think that's the other group that we'll see into the future. we'll see.
Okay, maybe a kind of follow-up question around coordination of care in aged care. So as a GP, if we have an unwell aged care resident who is positive for COVID, who's the first point of contact? Will the PHU already know and take over? So I guess from the PHU point of view, we hope to stay right on top of cases for a long time, and when they're confirmed, and there's just that caveat that Mark mentioned before about the indeterminate results. So there have been a few people who have just been on hold for a day, sometimes 2 days, awaiting the supplementary testing happening in Sydney. That's caught us up with people acting on that initial indeterminate result a few times. With that caveat, once it's a confirmed result, we would certainly hope that we know about that pretty much straight away, and we're interviewing people same day unless they come in on the 10 p.m. Kind of data download. So hopefully we already know, and the aged care facility will know, and they'll be liaising with you. But certainly if you think you've got a confirmed case in an aged care resident and they don't know about it and they don't know that we know about it, we welcome that call, absolutely. But normally it'll be through that normal mechanisms that work so well in influenza outbreaks. That's the coordination. John, this is back to your surgical mask. Can we keep used surgical mask in a Ziploc bag, airtight for a few days, and reuse it with the same user? Thinking ahead to future shortages of masks. I'm picturing 7 days of plastic bags.
Well, look, I'll take you back to WHO, who have a very good expert group, some Australians on that group, and they recommend against this practice. I know that it's commonly talked about. I guess the hazards are that it goes into a plastic bag and it gets mouldy because it's moist. The second hazard is that it's contaminated, and it contaminates surfaces that you don't know are contaminated, so you self-contaminate when you... yes, the virus may not have survived that length of time, you can worry about that. I think the whole process is fraught. I think if we are going to reuse masks, we need to actually sterilise them using vapour disinfection or similar. So that's the technology we want to use. It's been publicised on Twitter. I think Atul Gawande had a posting of 80,000 masks being hung in a room, and they're all sterilised at once. So that's the technology we'll have at John Hatter before the next couple of weeks, probably.
Oh wow!
So potentially we can do that on site, and that's the way I was planning to do it until I was told to stop. But we'll see how we go.
Good if supplies are okay at the moment. One, I think this comes back to me. The public and GPs have a right to know where cases are by specific suburbs, which should be published daily. They'll help people to be more aware in these areas. Do you want to answer this, John? No, sorry.
No.
John agrees.
No. So, look, there's a problem with small areas and identifying people. There's national legislation, but there's the background privacy principles, of course, that we all work by always. The specific COVID-related national legislation ensuring we maintain privacy of cases. And I have to tell you, there have been some horrible circumstances, even with just 250 cases in Hunter, New England, of stigmatisation through people being identified. It's very real. We've got stories of nurses being spat on. People are not behaving rationally around COVID. Lots of people are. There's lots of fantastic stories. But there's very good reasons to go very hesitantly into anything that it potentially identifies somebody. If you've got a new person in a suburb that's small and that's potentially identifying, I think that is something that we ought to be very cautious about. Now, I think the motivation here is, how do we know whether there is risk or whether we should change our behaviour, either as clinicians testing or as people in the community? And knowing there's one more person in a suburb in isolation who got off a cruise ship 2 weeks ago, actually that wouldn't help you in any case. What you really want to know is whether there is people there where there's a little cluster suggesting there might be transmission from unknown sources. And hopefully you can see that the evidence is out there. We're taking that very seriously. 3 people in that category is enough for us to trigger heightened testing and media. So we'll go public, we'll continue to do that. Where there are areas where we, we want people to focus. There has been a whole bunch of suburban level data out there. hasn't come from us. I genuinely don't think it's helpful, but we will work really hard. You saw the LGA kind of level data. I guess that's the other thing is we really, the data, we've said this a couple of times, but the data we're looking at today reflects history. You know, it's maybe from anything up to 2 weeks ago, people who were just getting infected, incubated for a while, you know, might be 7 days, took a while to get along to a GP, took a while to get a test. You know, it's potentially data that's really seriously out of date. Now, that's a problem for interpreting response to, you know, social distancing measures, of course. It's why we proceed with great caution. But we shouldn't be reassured by the numbers we've got to share today. We ought to be assuming COVID is around in our communities at low levels, fortunately. But yeah, I think that's an argument for not overweighting the postcode data.
So Tony, a case at point came up this morning. I learnt that the second case had been notified by the Health Minister in Papua New Guinea to a particular location in New Guinea. And the hospital executive there had no staff that day. The staff decided to stay at home because they're so worried they didn't have enough PPE and so on.
It's actually an issue in hospital and the home by the traditional visiting model.
Okay.
Because you know, people get into their PPE outside the door. That's the rule.
Oh, yes.
So you can imagine if you're in a block of units, someone turns up to your door and changes into their PPE. That's putting a big label on that person.
That's really challenging.
Yeah.
Again, but yeah, okay, we've got no alternative for the face-to-face stuff, but it reinforces the critical value of good quality telehealth when an initial assessment's been made. Okay, so great question, good chance to have a talk about that. I think we've covered off on the telehealth items for nursing staff, so that's something PHN will get back to you about. Right, so will hospital in the home model be operating on the Central Coast as well? I know you don't have jurisdiction there, Mark, and we might need to put the question to
We're working
John?
through that and we're in active conversations with them.
Can I just check whether John... Yeah, so John Bailey on behalf of PHN is just saying that those issues are being worked through at the moment and PHN will be able to get back to you with more information on that shortly. Thank you very much, John. So again, apologies, we hope to have more direct Central Coast input in any future webinars. All right. Now, here's a challenging question, Carolyn. What's the plan for COVID patients dying in the community in terms of palliative care? Is that fair to...
So I suppose what we've been talking about in the aged care facilities is I think a lot of the aged care facilities and a lot of GPs actually have really good palliative care skills and that the palliative care service is available for specialist palliative care consults. But again, a lot of it will be telehealth rather than necessarily visits. Does that answer the question?
Look, I think so. The palliative care, end-of-life care team is looking at, I guess, in the broader umbrella of support to aged care, palliative end-of-life care, hospital in the home. So, and there's some synergies there in terms of pooling resources and access to technology. So it's an active space, I guess. Yeah, it's a great question. John, COVID PCR, are they only 80% accurate as published by the Ministry of Health in a Southeast Asian country? We've touched on, I guess this is sensitivity in particular.
Yes, I think the early sensitivity data was showing around 75–80%, but I think that was the problem with that was that it was being taken from later cases, and so upper respiratory samples may not have been fully sensitive. But I think there's no good published data yet, but the feel of the laboratorians on Ausbug was that PCRs taken in that first 5 days of illness are likely to be much more sensitive, particularly if it's a good sample. So a deep nasal swab or nasopharyngeal sample plus a throat swab, I think, is worthwhile. I know, I think from Pop Health side, you're happy with the nasopharyngeal swab.
Yes.
I would doubt that most collections are of that site. They're mostly deep nasal swabs. And certainly the fever clinics are not trying to do nasopharyngeal swabs.
Yes, we are.
You are?
Yeah, yeah.
With the,
I
with
can,
the fine swab?
unfortunately,
Dr. Merritt can tell us.
might have been through the Belmont Clinic myself recently.
Oh, right, okay.
Complying with the area's, the district's policy for any healthcare workers who have a sore throat,
certainly-
however mild.
I hope they didn't try both nostrils though.
So, look, I have a lot more sympathy. I've collected many of my time. I have a lot more sympathy for the
Yeah.
process and a great admiration for the thoroughness of your staff member
Oh,
there.
okay.
If there was virus there, there was none.
Okay.
If there was virus there, they were definitely going to pick it up on
Yes,
that.
having had one myself, I was thinking that if you sampled the other nostril, they'd punch you in the face.
Yeah, I think I was not looking forward to the follow-up samples if I'd been positive.
Yes.
So no, that's certainly what was being done there.
So a good quality sample makes all the difference, yes.
And usually
Sure.
one nostril's better than the other, so sometimes people might get two samples down their nostril because they've,
Are you
broken
you're
their
sampling both
noses.
sides, are you?
No, but sometimes the nurse is saying, oh, we haven't been able to do a sample on the left, and
Yeah.
then they can get a good sample
if
from
it's
the
kind
right.
of physically, anatomically. So again, just to reinforce the sample, it's a single swab, both tonsillar beds, back of the throat, and then one nostril, and so that, and in that order, and then in the viral transport medium. So throat before nose is what I meant.
There's a really good video on New England Journal of Medicine YouTube video of how to do a nasopharyngeal swab. It's a 30-second video, so that I like those ones because they're really short. But it really demonstrates what you actually need to do a proper nasopharyngeal swab.
Mark, one for you. So what will be the criteria for admission from hospital in the home onto hospital care? So when people trip over beyond your service?
Sure, so that is in the pathway. Look, on oximetry, we're looking for people with oxygen saturations either 93 or below, or that have fallen 3% or more from a known previous level in a person with known disease. And then we have activities of daily living reduction. Then we have symptoms. We have our NH111 score, where we ask people a series of questions and listen to their voice as they answer them. And we also have a bottom thing for clinician discretion. If the person assessing it just thinks they look really bad, I think we have to accept
Sure.
that from an experienced clinician. Yep.
Excellent, thank you. There's been some questions about, you've seen the beta version, hot off the press, of the community management for COVID that's operational here in Hunter, New England as of an hour or so ago. But there is a central coast management pathway being rapidly developed, John. I think is that a fair summary? So appreciate that is something that's it's on the way, and the team here obviously very happy to contribute to pathways elsewhere. So, John, you've addressed this to some extent early on, but it's come up, is COVID-19 airborne or not? Some say it can hang around in the air for 3 hours.
So, yes, well, look, there are studies that sample large quantities of air and find virus in the air, and you can do this around for bacteria. For, all of the bugs we've got on us transmit into the air. As to whether that's relevant to transmission is another question. So, the receptors for this virus are probably in the upper airway rather than the lower airway. And the droplet nuclei, if the virus is in droplet nuclei, are delivered to the pockets of the lung, deep into the lung. So we know, for instance, tuberculosis is far more infectious if it's delivered into the alveoli of the lung with droplet nuclei. So that's a biological mechanism why airborne transmission works for that. It might be an infectious dose issue as well. We don't quite know the infectious dose, and perhaps the delivery of quantity from droplet nuclei is insufficient to cause infection. There is some sort of inoculum effect going on with COVID-19. That it appears that if you get a higher viral load given to you, you're more likely to develop illness. I think that's coming out of some studies. So, I guess going back to all the epi data, and there's quite considerable epi data, it's quite amazing what's come out. Really doesn't show any red flags around airborne transmission. So I think WHO is very comfortable with this. They really have their head, you know, WHO Geneva has very extensive technical working groups of experts that trawl over the data, and I've got faith in their ability to look at the big picture more than I can through, I think there's 2,800 papers now published on PubMed this morning on COVID-19. So we do rely on that those people with actual expertise and time to have the brain space to think about it. And I think it makes sense to me that this is not, we're not seeing a red flag around airborne transmission. So I mentioned measles and TB and varicella, chickenpox. All of them have very high reproductive numbers, above 10. This has got a reproductive number more in accord with other respiratory viruses that transmit by respiratory route, influenza, RSV and so on. So again, that reproductive number is not showing us a red flag.
What's the answer around surface contact then?
So their droplets are falling on surfaces and remaining, and the virus is remaining viable on those surfaces. And so we know that serves as indirect contact transmission. People touch those surfaces, touch their face, as I've been doing during this session.
Try not to.
It's very hard to when you've got a camera on you. And so famously, we know the story from SARS in 2003, that Hong Kong hotel, the Metropole Hotel, where the sick Chinese doctor from Guangdong province stayed at the Metropole for 2 nights. He was then admitted to hospital in Hong Kong and died soon after. And he cross-infected 16 other people in that hotel, but didn't have any face-to-face contact with any of them. And this suspicion is that the lift buttons and other common surfaces were contaminated by him, and those people then contaminated themselves. So definitely hand hygiene is a major issue for us around transmission of a lot of infections, and perhaps if nothing else we'll learn to clean our hands out of this. I think that message has gone around pretty well.
Well, and it does reinforce the importance of cleaning surfaces.
And cleaning environmental hygiene, certainly. Yeah. So our hands are only contaminated because of those contaminated surfaces, so we need to do both, most definitely.
This is, I think, one of the challenges we find, and GPs will too, in terms of counselling people with confirmed infection who are being managed at home, and they might be sharing a space. We'll always want them to be in a separate bedroom, use a separate bathroom, and where they're in a shared space, for example, living area, if that is not avoidable, to be wearing masks. But critical that any common surfaces are cleaned down thoroughly, repeatedly during the day. And certainly we have seen evidence, even within Hunter, New England, of transmission through what we believe were surfaces, just underlining the importance of that kind of attention to surface cleaning, frequently touched objects for people being managed at home. There's a question about complacency with the sense that we feel we are winning. I think we touched on that with a story out of New York. I think that's a real danger. Hopefully there's plenty of sobering stories around us, and we have the luxury of feeling that way for a long time. Okay, if someone is not a high-risk contact, e.g. a health worker with cold symptoms who has a COVID test and it's negative, how long do they need to isolate? John, I could ask you that. If you've got a healthcare worker consulting infection control at the hospital, they've had a COVID test but they've still got sore throat and coughing.
Well, we're expecting them to stay at home while they've got symptoms, basically. We don't want them coming to work walking wounded. If, for instance, they test positive for influenza, there's sort of a 5-day limit. Their symptoms might settle quickly, but generally not that quickly. So they're not supposed to come in while they're symptomatic.
Yes, look, I think that's something we have been in the past probably somewhat complacent about. But I think even if you have a cold and you come to work and you infect X many co-workers with that cold in the COVID era, that's a big problem that you've created there.
Yeah.
And so I think that it's sort of been a traditional doctor thing to soldier on, but perhaps you're not doing the right thing. So when people ask, we say, well, influenza we've got specific rules on, but we say, you know, that cough and runny nose need to be better. Of course, there are always the people who cough for a month after they've got a cold,
I think some private industry is doing that much better than we are at times. I know in Newcastle there are people who get their forehead temperature measured before they can walk through the door. Hopefully that's happening, something like that's happening at aged care facilities too, to really send a clear message about who can and can't come into the building. We're trying to model it in our workplace. That's why I worked from home last Friday and went to visit Carolyn's establishment and was out until I was symptomatically better and test was confirmed. And I think you're right, Mark. I think we just need to change that culture, particularly this
culture,
winter.
yeah. I think the staff have been a lot better. And the other thing we've been doing the ED, which is probably a good thing to think about for general practice too, is just having a safety huddle in the morning and going through all those things. Are you feeling okay? Is there anything you're worried about? And then it's a good chance to reinforce the messages around PPE use and what's the process if someone comes in sick. But I think, yeah, just checking, are you okay? Are you well? And that actually encouraging people and supporting them to make the decision to go home, because it is actually very culturally difficult, I think, for doctors particularly to not come to work.
And I think actually GP staff checking in with each other. So, you know, if you're in doubt, ring your colleague and find out what they think objectively, because we're hopeless at judging for ourselves. And we've just opened a staff advice line in Hunter, New England. I think 22 calls today, 14 of those were around symptomatic staff who couldn't make up their minds about their symptoms. So
I've been suffering with a new condition too. It's called psychogenic upper respiratory tract infection.
You should have a swab, Carolyn, I think.
No, you wake up in the morning and think, oh, is my throat sore?
I get itchy nose
I feel short of breath and my eyes watering.
Look, listen to us all. Okay. So we're very close to the end. I think we've got time for certainly one more, Mark, and it's the one on immunity. So is there any data to show if infection results in immunity? And can you be ill with COVID more than once? Care to comment?
That's another question. But we know from human coronavirus infections that there is immunity. As to how long it lasts, it's not exactly clear, but there is immunity. So I think it's very reasonable to conclude that immediately after recovery you will be immune. And antibodies seem to be important in coronavirus immunity. I think it's different to, for example, respiratory syncytial virus (RSV), where children will often have 4 infections with RSV in 1 year. Clearly, immunity is not good. That's not something we've seen with other coronaviruses. So I think as a duration, perhaps not clear, but I think there is good grounds to believe that there'll be immunity. I don't know what effect giving immune modulating drugs will have on that. You know, that it's that vaccine failure with chloroquine is described. It's in the rabies vaccine failure with chloroquine is well described, isn't it?
And we certainly hope a vaccine will be very immunogenic, or at least adequately immunogenic when we see one. Indeed. Look, I think our session actually ends right on that time, so there are some more questions, but we've got through the vast bulk of those, certainly those that were voted up. So, look, I thank you very much, Carolyn, Mark, John, for joining us again. Thanks for everyone who has hung in there and sent questions through, and appreciate that support. We hope you stay on and fill in the evaluation at the end there. We take that really seriously and it shapes what comes next. There's the issue on aged care and whether looking at guidance on whether that should be a standalone session at some stage. Great questions tonight, so it's been fantastic. We've covered some of that. And I think with 30 seconds to go, that's a wrap. John, did you want to say anything at the end? So look, thank you very much for joining us, and we'll look to do this again at some stage that's useful. Thanks kindly. Good night.
Thank you.